welcome back in the studio. I am very excited to chair this session with Eli Azoulay, the president-elect of the Society. Hi, Eli.
Hi, Maurizio. Hello, everyone.
And we are excited because this year we started a new guideline committee with the idea to provide more important guidelines at the bedside. And one of the first topics that we decided to have was really ultrasounds. And I have to say we had appointed a fantastic task force led by Chiara Robba and Antoine Villar-Baron. And I'm very excited now to see the results of this work, which is being accepted in our journal Intensive Care Medicine. So with great pleasure, I would like to invite Chiara Robba, an intensivist based in San Martino Hospital in Genova, in Italy, and also the future chair of the neuro intensive care section of our society, to present the consensus. And then there will be plenty of time for questions, and don't forget to put your questions on the chat. We will be together with Chiara, with Eli, and also with Adrian Wong to answer all your questions and comments.
Thank you very much for the opportunity to be here and present you the results of this very important consensus, which has been commissioned by the ESICM, and that included a huge number of experts, and that provided a huge number of statements on a topic which I believe is of extreme importance for the ICU clinicians. So the use of basic skill of ultrasound basic skill for the evaluation of critically ill patients. This is the agenda for the next 20 minutes. So why the need of doing such a consensus? Critical care ultrasonography is an essential component of the management and evaluation of the patients in the ICU, but at present, it's not actually clear which are the skills and the competencies which are required to the intensivist for a head-to-toe evaluation of ICU patients. And so the aim of this consensus was basically to provide a list of recommendations regarding what the intensivists should know regarding the basic skills on ultrasound for the evaluation of and the management of ICU patients. Which patients? We considered as a target population patients admitted to a mixed general neuro ICU, including trauma, neuro facilities, and including medical and surgical population, but excluding major surgery, cardiac and non-cardiac surgery. This is probably the most important slide of my presentation. I was lucky enough to have an incredibly high-level co-chair with Antoine Villar-Baron, a very expert methodologist, Daniele Poole, and Adrian Wong, who was again still part of a steering committee and who helped with images and with videos. And then we created a panel of experts from all over the world with different expertise in different subgroups and in different organs with according to their research and clinical skills and experience. And so we had one group who looked after and who produced the statement regarding the brain, one group who produced the statement of the lung, one group for the heart, one group for the abdomen ultrasound, and one group for the vessel ultrasound, and one group who looked after and performed the systematic review regarding the use of a teaching program, the presence of teaching programs and of training of ultrasound in the intensive care unit. So the panel, divided in this group, produced a number of statements which were then approved by the rest of the panel, and then they went under votation according to a modified Delphi method. And according to this, we obtained a different grade of recommendation. Strong recommendation when the agreement was above 85%, between 75 and 85% weak recommendation, and below 75 no recommendation. And we produced a total of 74 statements, 7 for the brain, the 20 for lung and for the heart and abdomen, and 7 for vascular ultrasound. And we were very happy with the results because we obtained strong agreement in 66.2%, in 8 cases 10% of weak agreement in favor, 3 weak agreement against, and no consensus just in few cases, less than the 20% of a statement. So starting from the brain, this was probably the most contrasting part of the consensus, probably because it's where we have to put a major effort in terms of research and training. We obtained seven statements. The first demand which was explored was the use of brain ultrasound for the evaluation of intracranial hypertension, and we obtained a weak agreement regarding the use of pulsatility index and the evaluation of qualitative waveform analysis to assess non-invasive ICP, but no consensus were obtained regarding the use of the optic nerve sheath diameter for the evaluation of increased ICP. And this was because it was considered probably too advanced and too specific for a general ICU physician. And this was exactly the same issue that we had in the other demands regarding the brain ultrasonography, like brain dead, vasospasm, evaluation of ischemic stroke, evaluation of cranial ultrasound for intracerebral pathology. No consensus was obtained in these demands, again, because this was considered by part of the panel as too advanced to be included as basic skill. And the panel had obtained a weak recommendation against the use of the autoregulation as basic skill, which was probably due to the technical difficulties and for the lack of important clinical applications at patients' bedside for this type of skill. Regarding the thorax, we obtained a huge number of strong agreement. We divided this topic in 5 different demands. So pneumothorax, pleural effusion, respiratory failure, airway ultrasound, and diaphragm ultrasound. Regarding the pneumothorax, basically the panel agreed that a combination of factors like the presence of lung sliding, lung pulse, B lines, etc., should be considered as factors that must be part of a basic skill for intensivists for the evaluation of a pneumothorax, and so the same for the presence and evaluation and identification of a lung point. And still strong recommendation was obtained regarding the use of lung ultrasound for the indication of pneumothorax drainage and to evaluate the location of pneumothorax drainage. Just a weak recommendation was obtained regarding the evaluation of a topographic projection of a lung point over the chest for the semi-quantification of extension of a pneumothorax. All strong statements and agreement were obtained for pleural effusion. So lung ultrasound is even more sensitive than the chest X-ray for the evaluation of small pleural effusions, and it also allows a good quantification of effusion volume. So strong recommendation regarding the use of ultrasound for the evaluation of the size, of location of pleural effusion, of evaluation of the presence of complicated effusion, and for the evaluation of the indication position for drainage or evaluation of complication in case of the use of drainage of pleural effusion. So this should be definitely a clinical situation where lung ultrasound should be used in the general ICU. Respiratory failure, even in this case, we obtain strong recommendation regarding some components. For example, for the evaluation of interstitial syndrome and for the evaluation of lung consolidation, lung ultrasound was considered by the expert as a valid tool to improve the differential diagnosis of lung parenchymal disease, impairing lung aeration, and also in the use of ultrasound findings to improve the accuracy in the differential diagnosis of acute respiratory failure and for the diagnosis of pulmonary embolism. But no recommendation was obtained regarding the use of lung ultrasound for the evaluation of the loss of variation in the anterior fields, for the distinguishment of focal and non-focal pattern, and to guide and to set the ventilatory strategies in patients with ARDS, as this is considered too advanced skill. Airway ultrasound, despite some literature exists regarding airway ultrasound, the panel provided a weak recommendation against the use of airway ultrasound, probably because of the lack of a standardized technique and for the presence of other clinical findings which can actually help in the evaluation of the position of the tube and to evaluate a successful or not intubation. And regarding the diaphragm, weak recommendation regarding the estimation of diaphragmatic expulsion and no recommendation regarding the use of diaphragmatic thickening fraction, which was considered by part of the panel as a too advanced tool and not supported by enough literature. Heart, again, in this case, 5 different demands. The first one was the evaluation of left ventricular systolic failure. The panel felt that a basic recognition of normal and abnormal echographic findings for the evaluation of global or regional wall abnormalities should be skills for, should be considered basic skills for the intensivist. The panel felt that no clarity, so no consensus was obtained regarding the use of transesophageal echocardiography as a basic skill, and most of the panel, at least half of the panel considered that transesophageal echocardiography should be part of the more advanced skill programs. Right ventricular failure, similarly to the left ventricular failure demands, the panel felt that the detection of right ventricular failure should be of great importance in the evaluation of patients admitted to the ICU with cardiopulmonary failure, and that the ultrasound evaluation of right ventricular failure should be important to inform diagnosis and prognosis of heart and lung interaction, and that these are all skills that should be easily achieved by a basic bedside ultrasound assessment. And therefore, we obtained 4 strong recommendations regarding the evaluation of right ventricular failure according to different criteria, to different clinical conditions. Pericardial effusion, similarly, the panel felt that the detection of exclusion of pericardial effusion should be an essential skill for intensivists, as well as the evaluation of tamponade, as well as the evaluation of the inferior vena cava to inform plausibility of tamponade physiology, and no recommendation was obtained regarding the use again of transesophageal echocardiography in the evaluation of pericardial effusion and post-procedural drainage of pericardial effusion. Again, the same reason was that this was considered too advanced. Evaluation of severe hypovolemia, again, in this case, in cases of shock, of mixed shock, intensivists should have an understanding of the imaging features of hypovolemic shock, and this should be especially for used in clinical condition of more acute or chronic case of volume loss rather than in very obvious acute volume loss and acute shock. And the last domain for the heart group was the use of the evaluation of left-sided valvulopathy. Basic echocardiography can identify and should be part of basic skills for intensivists major issues, major abnormalities of the mitral and aortic valve, which may provide clinical diagnostic information in patients with cardiopulmonary failure. With, however, the use of color Doppler for the evaluation of valvulopathy, which should be considered as well as basic skill for intensivists. Regarding the abdomen, the use of ultrasound for aortic syndromes has been encouraged and obtained one strong agreement. Bedside abdominal ultrasound has a very good accuracy for the detection of aortic abdominal aneurysm, so strong recommendation regarding the use of ultrasound in this clinical context, and 2 strong recommendations regarding the assessment of kidney health and the urinary tract, and in particular for the evaluation of the presence or absence of hydronephrosis or bladder over distension, but no recommendation was obtained regarding the use of a renal Doppler resistive index, which is a promising tool, but it hasn't been yet extensively validated in relatively inexperienced operators. And then regarding the non-traumatic acute abdomen, some skills regarding the use of ultrasound for the detection of intramural gas to rule in the diagnosis of non-traumatic acute abdomen definitely need further evidence and more advanced skills. But some skills, like for example the evaluation with a clinical, considering also the clinical context, but the evaluation of free fluid in the peritoneal cavity for the identification of non-traumatic acute abdomen, have been considered by the panel as a basic skill for intensivists. And regarding the traumatic acute abdomen, well, we all know that abdominal ultrasound is a fundamental component of the FAST, and so the panel agreed that basically the evaluation of free fluid, blood, should be basic skill. Should be considered as basic skill for intensivists, integrated with a clinical evaluation and as an integral component of trauma resuscitation. Weak agreement was also obtained regarding against the use of RDRI of the interlobal arteries, which has been previously considered in the previous demand, because even in this case, although this could be an important factor, an important sign of hemorrhagic shock and hypovolemic shock, this is still considered too advanced skill. And other applications which should be considered in both acute traumatic and non-traumatic skills have been then evaluated, but in most cases the presence of free fluid and the presence of big effusion in the characteristic of the effusion and the use of ultrasound as tool to help in the evaluation and in the treatment of the effusion should be considered as basic skill in both traumatic and non-traumatic acute abdomen. And regarding the vessel, this was probably the domain where we obtained the most of the agreement. The two major demands were the vessel cannulation and the deep venous thrombosis. Regarding vessel cannulation, strong agreement was obtained regarding the possible use of ultrasound in the cannulation, in the arterial cannulation and in the venous cannulation in case of multiple fail attempt, in case of when the arterial pulse is not palpable, and to guide and to assess, to detect the size, the position and the pathesis of the target vessels, as shown here in the figure, and for a continuous visualization of the needle tip during its trajectory in and out of plane, to avoid complications and to avoid mistakes and errors in the cannulation of the vessels. So a number of 6 strong agreements, strong recommendation regarding the use of ultrasound for vessel cannulation. And finally, one skill, one recommendation, strong recommendation regarding the use of ultrasound for deep venous thrombosis. In fact, the compression technique, when applied from the common femoral vein and at the groin of the popliteal vein, has demonstrated to be accurate in the diagnosis of deep venous thrombosis, obviously considered together with the clinical context, but it has high sensitivity and specificity, and therefore it should be considered a basic skill for intensivists. So all strong agreement regarding the vessel cannulation, probably because it's also the demand where we have the majority of evidence. So in conclusion, I think that we were able to provide with this consensus a large number of statements. We try to cover as much as possible all the clinical context of the target population that should be considered for ultrasound basic skill, and that intensivists should possess and acquire for the evaluation of critically ill patients. In most cases, when consensus was not obtained, the reason was that these skills were not considered basics, but they require an advanced teaching program. It's very important that, that to clarify that this document should not be read as a potential medical legal document. So it should be considered as a guide for the intensivist to acquire competencies, and it should be considered, we believe, as a core for any courses and training program, at least those endorsed by ESICM. Of course, there are some limitations. The principal one is the lack of a systematic review and of a literature, but the experts were selected according to the amount of papers and the literature that they have provided, and they have anyway performed a huge revision of the literature before performing the skill. I believe that this is going to be just the first step. In fact, important questions still have to be addressed regarding this topic, and it's very important that we don't stop here, because we gave some answers, but there are still a lot of questions which arise from this consensus, and this should lead to the development of future research and training program. And I will be very happy to continue to work with ESICM and with the panel to provide more evidence and to provide more training and educational program on this topic. And I thank you. I thank you for your attention. I thank ESICM for this great opportunity. And once again, thank you very much to the panel and to my colleagues for helping me and for providing such an incredible work that I hope will be useful for the clinicians who work in the intensive care unit.